We've all been there as physicians and health practitioners where you have that one clinical encounter that is so exhausting and it just drains your energy for the rest of the day. And this can sometimes happen when you are working with patients struggling with insomnia. So today we're going to be talking about how to deal with that draining clinical encounter with the patient who insists on being prescribed sleeping pills when that's not what's clinically indicated or helpful for them, and then you're exhausted by the end of it. Today we're going to talk about how to deal with this. I'm Dr. Nishi Bhopal. This channel is for you as the physician or the healthcare practitioner to learn more about integrative sleep medicine. I'm an integrative psychiatrist and board-certified sleep medicine physician. If you ever work with patients who are struggling with sleep issues, go ahead and subscribe to this channel. And I'd also invite you to get my free melatonin brand guide. Many of our patients are using melatonin, but there are significant quality concerns about melatonin supplements. Go ahead and get my free brand guide for your clinical practice. I'll put the link in the video description. I did my residency in psychiatry at Henry Ford Hospital in Detroit, and I decided to pursue a sleep medicine fellowship after my psych residency. And I was doing rotations at the sleep program at Henry Ford, and one of my attendings there, Dr. Chris Drake, he was giving me advice on interviewing for sleep medicine fellowship, and he told me to say in my interviews that I was really interested in treating insomnia because so few doctors want to deal with insomnia, because not only is it frustrating for patients who are suffering, but it also can be challenging for the doctor for a variety of reasons. And we're going to get into that a little bit today and talk about how to deal with this. Dr. William Dement, he was the father of sleep medicine, and he directed the sleep medicine clinic at Stanford. He said, most physicians dread the arrival of a chronic insomnia patient. If one asks a large group of doctors if any of them enjoy managing chronic insomnia, not a single hand will go up. This is partly because doctors get such little training in sleep medicine. Most doctors only get 0 to 2 hours of sleep medicine education during medical school or during their medical training. Also, as physicians and healthcare practitioners, we really don't get much training in CBTI or cognitive behavioral therapy for insomnia, which is the first-line gold standard treatment for insomnia, unless you go and pursue additional specialty training in that. And the medications that we have for insomnia are really not all that effective. And in fact, these medications often make the problem worse. They're really not indicated first line for treatment of insomnia. They have side effects. They can lead to physiological or psychological dependence. And then this can reinforce the feelings of helplessness that people are struggling with when they have insomnia, the feelings of loss of control, reduced sleep confidence. And then they start trying all these other medications to try to solve the problem, or reaching for other external things like supplements and things like that that don't actually help. And then you as the physician, you're seeing this patient who maybe has tried a laundry list of things. They maybe want to use benzos or hypnotics and other medications that have a lot of side effects, aren't really indicated for long-term use, and then you end up in the situation where you're bargaining with the patient or they're bargaining with you. They may have even engaged in doctor shopping and you're the next one on the stop, and your patient is just looking for some relief. They're not trained in managing chronic insomnia, and then it leads to this situation where both of you are just exhausted by the end of the visit. So I'm going to share 3 steps to deal with this kind of scenario. The first step is to set the scene. This is where you really want to engage in active listening, show genuine empathy for the patient, acknowledge their concerns and their frustrations. And even just letting the patient talk for the first 60 or 90 seconds of the visit can help them feel like they are being heard, that you're building a rapport with them. And again, this is not about faking empathy. Genuinely, it's concerning when somebody is struggling with insomnia. They are in pain. They are suffering. You can even share with them, look, I know you've tried a lot of things. I know you're suffering and you just want some relief. I hear that. The other aspect of setting the scene is having boundaries with your time, because you're in clinic, you've got other patients that need to be seen, and if you run over late with this one patient, that's going to make your next patient late, and so on. It has a domino effect, and we have to take all of that into consideration. So setting up those boundaries at the beginning of the session, because sometimes these sessions can go on a little bit longer. If you've been there, let me know in the comments. So even letting the patient know, like, hey, I know we have a lot to talk about today. We have until X time. We have until 10:30, or towards the end of the session, give them a 10-minute warning, because sometimes it can take a little bit longer than just a few minutes to wind down and wrap up. So I know we have to wrap up in about 10 minutes. Let's make sure we help you leave with a plan that makes sense for you. So this is all part of setting the scene. The next step is to really focus on your responsibility. What can happen in these kinds of patient encounters is that sometimes, especially if you're an empathic person, as a physician, you can start to take on the anxiety of that patient. And we want to make sure that we're not falling into that role where we're taking on all of that anxiety. We can be empathic with it, but we don't have to absorb it ourselves. So we want to make sure sure we have boundaries around this. And in psychiatry, we always say, don't work harder than the patient. Our responsibility here is actually to be an objective witness, not to be taking on all of that anxiety and the emotion from the patient. We want to be an objective, grounded sounding board for them and provide evidence-based information. Our responsibility is to share our clinical assessment. We also need to be making a differential diagnosis and figuring out, is this actually insomnia? You can see my video on the differential diagnosis of insomnia, because insomnia symptoms don't actually mean the person has insomnia. There could be something else going on. It is our responsibility as the health practitioner to figure that out. What actually is this? And what's the appropriate intervention for that? Is it a circadian rhythm disorder? Is it sleep disordered breathing? Is it restless leg syndrome or something else? Our responsibility is also to make a recommendation based on our clinical assessment. For example, I'll tell patients, hey, these are some of the things that we can work on. Medications really aren't helpful for situations like yours, and I have seen situations like this before where people are trying different meds and they don't work. So these are the things that actually do work that I recommend. We can work on sleep efficiency training. We can work on circadian regulation. It sounds like there's a lot of anxiety that we need to address. I think we should work on that. I also want to make sure you don't have any other medical issues like sleep apnea, like thyroid issues, or other things that could be contributing to your symptoms. And our responsibility is also to really help your patient build sleep confidence. We want to instill hope for them. Sleep issues are highly treatable with the right approach. I'll also tell people, look, there's room to work on nutrition, lifestyle. There's so many things that we can do. In the comments, let me know if you ever encounter situations like this in your clinical practice and what helps you navigate these types of conversations with patients. Okay, step 1 was setting the scene. Step 2 is focusing on your responsibility. Step 3 is to let the patient decide the next steps once you've given them your recommendations. So here you want to help them figure out if their goals are aligned with your recommendations. You can say to them something like, what's your understanding of what I'm recommending? And how does that fit in with your goals and your ideas about how to solve this? What I do is I'll tell patients that sedatives, hypnotics, these benzos, they're really not indicated or helpful for chronic insomnia. Meds rarely help and they often just make the problem worse. So my goal for you is to help you safely wean off while we use other strategies that are proven to work. Things like CBTI or cognitive behavioral therapy for insomnia. There's lifestyle interventions that we can try as well, and we'll work together to taper off. Here's my recommendation and let me know what you think. Does this align with your goals? So we're really putting the ball in their court. And you can even, again, show empathy. Look, I really wish there was a pill that I could give you that would just take this all away and make this all better. But it really doesn't work that way. And the power to make the change to overcome insomnia, it's really yours. And I can give you the recommendations to help you get there. And then what happens is typically one of two things. And this is what I found in my practice, is patients either get excited to have a plan. Wow, no one's ever talked to me about this stuff before. That sounds really good. I'm really excited to be able to get off meds. I didn't even know I could treat this without meds. That's usually one reaction that I get. Or the other reaction is they'll self-select out and say, oh, you're not going to prescribe me Klonopin? Okay, I'm going to keep shopping. I had a patient who came to clinic and she had been on Ambien for a number of years. She was on higher than the FDA recommended dose for women. She was on 10 milligrams of Ambien every night. And I shared my recommendations with her that, look, I really don't recommend this for long-term ongoing use. There's lots of other things that haven't been tried that we should work on, and that's going to help you wean off medications. And the patient's response to that was, no, I just want to keep taking Ambien. I don't want to do all of these other things. And she self-selected out and found another doctor to prescribe the medication. So as the physician, you're going to have your evidence-based recommendations. You're going to have your clinical approach and recommendations. And if patients don't want to follow, that's okay. That doesn't mean that what you're recommending is wrong. That doesn't mean you have to prescribe treatment plans that you're not comfortable with. And your job is to give your patient the best recommendation that you have based on your clinical experience and the evidence. You want to make sure you document all of this in the chart, document your recommendations to the patient and the patient's decision. There was a classic article from 2005 called The Difficult Patient where they talked about some of these issues. And one thing they said was that attempts to solve problems with psychopharmacology, unless carefully introduced and based on a correct diagnosis, may also prove problematic. And that is true for patients who are struggling with insomnia. We have excellent treatments that are actually very effective for insomnia that do not involve psychopharmacology. And you may find that actually trying different sleeping pills with patients actually ends up making the problem worse rather than better. So I hope this was helpful for you. 3 steps to deal with those clinical encounters that can leave you and the patient feeling exhausted. If this was helpful for you, go ahead and click the like button and share this video with another colleague in your life who could benefit from this information.